Our next speaker is Mr. Andrew Webb, and again we're looking at best practice. Andrew is a senior scientist for the blood bank lab at Alfred Health for 20 years. He holds a Master of Medical Science from Royal Melbourne Institute of Technology, of Technology University. Andrew, let's hear your story.
Thank you very much. I must thank Karen, who contacted me to come and talk today. It was a bit of a surprise, but I do thank you for the acknowledgement. And hopefully what we're going to be talking about here is not meant to be anything apart from a personal perspective, so cherry pick what you like. If I can defer to Greg, I may not take that be positive, be negative message to work. We have a slight cluster event and they might take offence to that, so I might pass on that one. So just to give you a bit of an overview of the Alfred Hospital as a general institution. Just for the first 3 months this year, we saw over 17,600 patients. There were 7,300 emergency admissions alone. So we've got a very diverse, large institution. We service not only the Alfred Hospital campus, we look after Sandringham District Hospital, Caulfield, and the palliative services and respite at Bethlehem. So we have a multiple campus institution with a small satellite service at the Sandringham Hospital. In our blood usage, we have certain advantages. With our patient demographics, we actually have a capacity to move significant numbers of products. We are one of the 2 acute trauma services within the state of Victoria. We have a very large haematology oncology unit and a significant component of stem cell transplantation servicing that unit. In addition, we also have a very active solid organ transplantation team in cardiothoracic, respiratory and renal. To give you a bit of a workload context, we would service between the campuses between 38 and 40,000 group and saves per annum. So if you consider that there has been a clinical request for a group and save, there is a clinician who is deciding that a transfusion may be needed. So how we manage those requests has been a critical issue. Just to give you an oversight of what products we do use, so basically for a 1 year period, we would get between 1,000 and 1,300 units of red cells per annum. Oops. Hang on. There we go. And we waste about 20 to 40 units per month of red cells. Likewise with platelets, and I think we can all agree that platelets can be a bit of the bugbear because of their short life expectancy. We would get between, say, 300 and 350 units per month. About 66% of those units expire within 2 days, and about 38% expire within 24 hours. And we've been able to maintain a wastage, in essence, about 50 or just below. Now, I think one of the critical points in any transfusion response to blood wastage, it's got to be a collective process. Every part of the transfusion team, from the clinical, the laboratory and the ward staff and nursing, is integral to this process. It is important to identify all the stakeholders within the institution and incorporate them into the decision making and buy-in for minimising the wastage. You must also have very clear, defined lines of communication to all units. Where do we start? I think from what I've observed with all the flurry of activity after the standards came out, the executive did actually start to take notice. And I think we've had a transfusion committee which has been very active for over 20 years, but the uptake and the enthusiasm increased dramatically after the new standards came out. And I think it's important. With the executive buy-in, it actually was able to move things within the institution. People listened. They were able to get executive sign-off for policies and decisions. So the terms of reference of our transfusion committee was promoting best practice for transfusion. It is active, so there are willing participants who are there because they believe in the message. It covers multiple disciplines within our hospital, and it provides a high-level forum to communicate issues. It works in conjunction with the clinical governance unit to devise and review policies and practices. Another important feature, it oversees all the wastage events. And it supports national and state projects to optimise all our inventories. The representatives include the Australian Red Cross, haematology, the blood bank science, anaesthetics, transfusion nurses, clinical governance, and the clinical services director. Deriving directly from this is the key performance indicators. So from a very highest level, there are people who have said, these are what we want to see with our wastage. And that gives you what the figures are from our transfusion committee down through the network institution. Now, I'm obviously in the laboratory, so this is probably where I can speak most to how we minimise the wastage that we can control. Firstly, and it's a job everyone loves, because we've got a giant big cool room. And one person's job every morning is to go into that cool room at 4 degrees and count everything. They sort everything, they put it into expiry date order, and that is their task. Irrespective of what else happens, we cover all the other work. That is their dedicated task. Everything which is within a 5-day of expiry has a hideously fluoro sticker stuck on it, and it's put to the front of the inventory. Within the low frequency groups, the B negatives, yes, we still get B negatives, and we actually will move those into the front of the B positives. Likewise, the A negatives, we will move those into the front of the A positives, etc. So we'll always move a lower frequency near expiry group into the highest frequency group as our first choice. We're not too fussy about swapping blood groups if there's no other considerations such as antibodies. And we have lovely little stickers that tell the wards we know what we're doing, and yes, the blood group is different. You'd be surprised we still get the questions. Okay, irrespective of what the clinician orders, everything is a group and save. If you ask for a 1 unit or a 4 unit, we don't listen, we just test it as a routine group and save antibodies screen negative. If the antibody screen is positive, that is the only exception. We will touch base with the clinical units or through our clinical haematology registrars in the lab to assess what the potential is for blood requirements for any procedure or inpatient management, and then cross-match an appropriate number of units so the blood will be available for the patient as required. One of the things which has come in recently is part of our blood bank looks like an airport departure lounge. We've got a giant screen, and every order that comes in from the 3 main test areas, which is a haematology oncology unit, the intensive care, which I think, correct me if I'm wrong, could be the biggest in the Southern Hemisphere, and the outpatients haematology oncology is electronically ordered by the clinician directly to the blood bank. Now that has the advantages is that they have to go through a series of pro forma providing haemoglobins or platelet counts, which provides a readily audible data that our transfusion nurses and the clinical transfusion team can assess to see about the appropriateness of blood orders. As the orders come in, they are sorted based upon the unit and the urgencies. The urgents go to the top, then ICUs, etc. And as we work our way down, the arrivals get posted off into the completed, so we don't even have to phone up the wards. They just check the computer and they see that the blood product is ready for that patient. In the new computer system, we are actually looking at expanding that even further. So there'll be a real-time update on the page as the ward staff go into the patient's records, and they will see antibodies, blood groups, and every product that's been issued, available, or transfused, along with any transfusion reactions or haemoglobin results. Likewise, with platelets, we have a very flexible policy. If a day patient or a theatre patient comes in, they order platelets in advance, we will set them aside, we don't allocate them. At the end of the day, or at about 4 o'clock, another job is the evening person will come along and they will remove them from allocation to that patient back into a general inventory. As does happen with platelets in particular, they get near expiry. We will discuss with our haematology registrars and give them an idea of how many platelets are near expiry. They will then talk and liaise with their clinical unit teams on the ward, and they will see are there any patients in the haematology unit in particular that could benefit from a platelet transfusion in the evening of those platelets instead of waiting for the morning, because these are a captive population that are always getting transfused. they will often use them in the evening instead. So that's one strategy we've had to minimise the platelet wastage. And we've had some very interested people in the laboratory who've also involved in the validation of the extended life plasma, which has led to some significant decreases and optimal utilisation of platelets, plasma that's been thawed, particularly in the context of trauma where it may have been thawed in the heat of the moment, but is no longer required after a more careful clinical review. Likewise, we monitor all wastage events and that are reported to us, and instead of just document it, we actually put in an electronic risk log that a product has been wasted, from there, where and why. This then gets reviewed to myself, to my principal scientist, and to the transfusion nurses, and to the unit nurse of the area, and we can actually look for any trends, cluster events in the transfusion wastage and try and address them either through a one-on-one or through an educational program. Transfusion nurses. Where would we be without a transfusion nurse? My stepsister is an oncology nurse, and talking to her, sorry, my colleagues, but we have a reputation of being anal, inflexible, picky, and it's just generally nice. In discussions that she's had with her transfusion lab, she says, stop talking to R2D2. There's just no one who can understand what we're talking about because we come from a very pedantic basis. So I look at the transfusion nurse as like the C3PO. They're the translators, they're the communicators, and I think they perform one of the most vital functions. They provide an interface bridge between the ward staff, the clinical staff, and the laboratories, because we do speak different languages. What they tend to do is, within our institution, they review all the wastage, they compare to the KPIs, and importantly, they report to the transfusion committee and clinical governance. So the figures go back up the chain for managerial and executive review. They audit all product usage, and in particular with the use of the electronic blood ordering, that becomes more accessible because the clinicians have to place that data into the system. And I've seen Chris has had pages and pages of all the products that we have issued out, looking for any trends. One success story we have had where the transfusion nurse came on board, in the lab we would complain, blood's come back after 30 minutes, we've got to throw it out. And there'd be a lot of muttering because 10 minutes later they'd ask for the next unit. When Chris came along, she said, well, why did they send it back? Well, we don't know. So when she went to the wards, the drip may have tissued, they hadn't consented the patient, or a range of reasons they couldn't transfuse the product immediately within that 30 minutes, and they thought the best thing was to send it back to us, not knowing that we had to discard it. Chris then said, well, you've got 4 hours to transfuse that product, so why don't you keep it up here if the transfusion is going to be completed within 4 hours? And I would say that's actually been a success when Chris developed an educational program and she targeted the high blood volume user units, went up, educated them, and I'd say blood wastage from that reason has dropped considerably within our institution. So that process of understanding both sides of the equation I think is critical, and the capacity to understand the end user, develop a process and efficiently communicate it is critical. And they've been involved in identifying a large number of processes within our institution, within high blood user units, of checking identifications, safe transfusion practices, and the list goes on. And again, they will follow up all the risk man reports, and they will report those to myself if it's issues to do with us in the laboratory, or they will sit down and brainstorm with us about possibilities we can for addressing storage in particular areas, transport between institutions, etc. And as I said, they're the universal translators that translate lab speak into everyday person speak. We speak about communication going from the top down. I think in any system where we're looking to improve services, there's got to be the reverse, from the ground roots back up to get a complete loop happening. So this starts with, in my laboratory, with the staff. They might identify issues or concerns or constraints in a lab meeting. We'll then feed that up into an internal transfusion services meeting, which will involve the principal scientist, myself, transfusion consultant, the transfusion nurses and registrars, to ascertain what the issues are, if any, and look at any potential strategies. That will then report up into the transfusion committee, which can have the executive oversight to see if any policy directions need to be changed, amended, or if there are any issues that we haven't considered in the past. And that, as I've said before, consists of the medical executive, nursing and laboratory clinicians. The clinical staff in the laboratory are again an integral part of the whole transfusion process. From our point of view, they provide an essential clinical support. Now, I'm sure we've all been in that situation. You might get some unusual requests for blood products. Someone might want 6 units of blood for a total knee replacement and he insists this patient definitively needs it. So they provide a resource for us to go and filter all the requests through to see what is truly necessary to transfuse or not. And we will check with any of the clotting results or the haemoglobin, refer those through so they can make a proper, educated medical assessment of the requirement. In our institution, particularly with acute trauma, we tend to issue products on an as-need basis. So we will have involved the clinicians and the laboratory team very rapidly in this process of any acute trauma. They will feed off the results and recommend individual products tailored to that individual patient's requirements in the trauma. And we've found that that minimises certain degrees of wastage, particularly when it comes to FFP. And again, they provide a clinical interface to the ward clinicians, again to help us minimise wastage with platelets, but more so to explain issues. Because in the past I've found it a little bit difficult to explain things to some clinicians because they don't really believe what I'm telling them. And they facilitate an education transfer between the ward staff and the laboratory staff. The clinical staff. This has got a lot better. In the past, we've had an issue, and it's been touched on before, that a lot of our products aren't necessarily valued because they're seen as free. Now, that's starting to change, particularly with the price, which I support going on to the units. I think that's been a very positive mood. They're involved in the education of their fellow colleagues, and that's been touched on as well. The clinical laboratory staff can touch with the junior medical staff. The senior staff can be in liaison with the haematologists on the ward to get the message across about the best practices for transfusion. And once they buy into that process and become party to it as involved stakeholders, they will also take ownership of it and communicate it through their chains of medical responsibility. They're also the primary people who order the blood products. They're the end users. And so they are important in devising the transfusion guidelines that are used in the hospital. And as a result, they've also recognised that the fact that we are using electronic ordering as important because it gives them real-time flexibility. If they want 1 unit, they get 1 unit of blood. We only hold that unit for 48 hours, and they know that. So we can tailor the transfusion requirements specifically to the requirements as needed. So, overall, what minimises wastage? Everyone needs to have ownership. It's not just the laboratory trying to push the point. It's not just Red Cross. Everyone needs to be involved in that process. You need to have an executive buy-in that puts clear-cut, defined key performance indicators of what they want the institution to achieve. You need to have an effective series of communications within the hospital group, and I can't emphasise enough the importance that I view the transfusion nursing team has in that as a bridge. And you need to have a continual, robust system of audits of all wastage and reporting. And based upon that, devise programs which will educate the key points to the hospital. Where would I like to see things go into the future? Well, we plan to roll out electronic orders hospital-wide. Dare we hope, he says to the National Blood Authority, for RFIDs. It's interesting, I can track an iPad which costs $700 all the way from Ireland, but I can't track a unit of blood for $340 once it leaves my window to the first floor. And I think that's somewhere we could go. And I've also spoken earlier about BloodNet and how we can enhance that. Cold chain. We deal with a lot of adult haemophilia products, and it is just cold chain from door to door, which we sign off on. One thing we could do with BloodNet perhaps is when we transport blood between our sister campuses or from BloodNet is actually timestamp things, have that process automated, and it says if it's packaged to the correct configuration, it is acceptable for receipt. Thank you very much.